Rapid removal can cause hypovolemia and precipitate shock. When the procedure is completed, document the drainage on the client's intake and output record, and send specimens of the fluid to the laboratory for analysis. Keep the client on bed rest until vital signs are stable. Some clients with severe ascites may require surgery. A Levine shunt continually moves ascites fluid from the abdominal cavity into the superior vena cava. Following surgery, it is important to measure abdominal girth and intake and output, weigh the client daily and assess for bleeding, congestive heart failure, and peritonitis. Clients who have liver cirrhosis face the possibility of many dangerous complications. They include portal hypertension, esophageal varices, gastrointestinal hemorrhage, splenomegaly, anemia, hepatic encephalopathy, and hepatic coma. Portal hypertension is caused by a backup of blood into the portal system. As you can see, the portal system contains the gastric veins, mesenteric vein from the intestines, splenic vein, and portal vein. These veins drain through the liver and out of the hepatic veins into the superior vena cava. When the liver is scarred due to cirrhosis, blood backs up into the portal system, causing congestion, increased fluid pressure, and portal hypertension. Unless portal hypertension is surgically corrected, the client can develop esophageal varices due to congestion and dilation of the esophageal veins. These varices can rupture, causing a massive, life-threatening hemorrhage. It is vital to take every measure to prevent bleeding. Have the client eat a soft, fiber-free diet and take stool softeners to prevent straining to defecate. Also, advise the client to avoid products containing aspirin, which reduces clotting time. Injection sclerotherapy may be performed to sclerose bleeding esophageal varices. When the client is at severe risk for hemorrhage, the physician may insert a multi-lumen balloon tube, such as a Sangsteigen-Blakemore tube or a Minnesota tube. The tube exerts pressure on the bleeding varices, thus controlling the hemorrhage. Let's say your client has just had a Sangsteigen-Blakemore tube inserted. During your frequent assessment of the client's airway, your client reports dyspnea. What do? When a client reports or exhibits dyspnea or respiratory distress, you should deflate the balloon immediately. The inflated portion of the tube might have been pulled up into the oropharynx. Shunting surgeries provide a last resort for clients who have bleeding esophageal varices. During a splenorenal shunt, the spleen is removed and the splenic vein is anastomosed to the left renal vein. A portocaval shunt diverts blood from the portal vein into the inferior vena cava. During a mesocaval shunt, the superior mesenteric vein is anastomosed to the inferior vena cava. A high mortality rate is associated with these surgeries because clients may have coagulation problems. They might be malnourished or prone to infection, and they might have a low tolerance for anesthesia. Hepatic encephalopathy represents the end stage of cirrhosis and hepatic failure. This condition is characterized by neurological symptoms such as a reduced level of consciousness, impaired thinking, and ultimately coma due to the accumulation of ammonia and other toxic metabolites in the blood. Cephilac, trade name lactulose, is administered to the client to reduce serum ammonia levels. Cholecystitis is an acute or chronic inflammation of the gallbladder. Cholelithiasis is the presence of calculi or gallstones within the gallbladder or in the biliary system. The biliary system is composed of the gallbladder, the biliary circulation, and the ductal system. Bile, produced in the liver, is transported via the left and right hepatic ducts to the gallbladder. The gallbladder acts as a reservoir for bile, and it concentrates bile by absorbing water and salts. When a person ingests fats, the gallbladder releases bile into the duodenum through the sphincter of ati8. Bile is a digestive juice, and it also promotes peristalsis. Bile pigments, derived from hemoglobin, impart a brown color to intestinal contents and feces. Abnormalities that interfere with the flow of bile produce jaundice. The restriction of the flow of bile can also produce gallstones. Gallstones can form in the gallbladder, the common bile duct, and the duodenum. There are two types of gallstones: pigment stones that are made of bile pigments, and cholesterol stones. People at most risk for cholecystitis or cholelithiasis are obese women who have several children, take oral contraceptives or estrogens, eat a fatty diet, and are of Caucasian or Hispanic origin. It is helpful to remember the risk factors for cholecystitis by these 5 F's: fair, 40, female, fertile, and fatty diet. There may also be a family history of gallbladder disease. Clients experience different signs and symptoms, depending on whether their condition is acute or chronic, or involves the presence of gallstones. With acute cholecystitis, the symptoms are epigastric discomfort after meals, biliary colic, severe right upper gastric pain radiating to the back or the right shoulder, high fever due to inflammation of the gallbladder, nausea and vomiting and flatulence, bloating and belching. With chronic cholecystitis, the symptoms are vague abdominal pains, low-grade fever, jaundice, clay-colored stools due to lack of bile pigmentation, steatorrhea, or fat in the stool, dark urine, and fat-soluble vitamin deficiencies, that's vitamins A, D, E, and K. With cholelithiasis, the symptoms are abdominal pain, varying with the size and location of the gallstones, and the degree of obstruction, intolerance to fatty foods, severe biliary colic with diaphoresis, tachycardia, and pallor, a sausage-shaped mass in the upper abdominal quadrant, and jaundice when the bile ducts are obstructed by stones. Cholecystitis is diagnosed on the basis of laboratory studies, gallbladder ultrasound studies, and radionuclide imaging. Clients may have elevated serum liver enzymes, an elevated leukocyte count caused by the inflammation of the gallbladder, and in those who are jaundiced, elevated bilirubin levels. Clients might also have a positive Murphy's sign. That is, when the examiner places a hand at the costal margin in the right upper abdominal quadrant and